Oh. After this minute of silence, every day we thank to our defenders, especially who are on the front line, for this opportunity to have this meeting, that we have another meeting here in Odessa in spring on our Filatov's readings from our organizational committee. On my behalf, I want to greet you, my dear colleagues, our guests who join us with the opening of our International Scientific and Practical Conference, Filatov's Readings. Today, it's not another one conference. We have an anniversary, 150 years from the date of birth of academic Filatov. His name was listed and inscribed with golden letters in the history of both local and world ophthalmology. He developed new methodology of treatment of eye disease. He launched the school of talented students who followed him. So I hope that today's our Filatov's reading will be a bright event in our professional life. And today, tomorrow, we will have a lot of events, plenary sessions, reports, workshops, exhibition. All these in order for you to be entertained and to get new knowledge. We wish one another good and fruitful days of this cooperation, successful cooperation, discussions, interesting discussions, new meetings, new impressions. Let's wish one another health and health to our patients, which we want to support. Let's God bless you as the opening of our conference.
найважливіші
Uh,
досягнення медицини
co-
ХХ століття.
Cornea
Більше
transplantation is
110
one of
років
the
на
best
дозвіл, і
investigation
при проведенні цієї
and
операції на
opening of
ефективному
20th
методі
century.
боротьби із
And
гепатою інвалідністю
our
втраченням
scientists
вільного.
spent a lot of years in order to
Серед цього
improve
напрямку
this
слід
surgery.
згадати
One of
офтальмологів
the
Карла
beginners and
Гінеля,
pioneers
Франца
are
Резініра,
Carl Gienel,
Едуарда
Franz
Петра-Симона,
Resengier, Edward
Антона
Konrad Zine,
Євженіка та Олександра
Anton
Філіповича
Lenzschmecker,
Шиманського.
and
Через рік
Alexander
називали ім'ями
Shimansky. Their
пересадки парохів.
investigations were the
Однак
fundamental
особливе
of
місце в
cornea
історії науки
transplantation,
належить
but
Володимиру
the
Петровичу
main
Філатову,
place and
видатному
special
українському
place
офтальмологу,
is
який присвятив
of
своє життя
Volodymyr Filatov.
вирішенню
He
цієї
dedicated
складної
his
проблеми.
life to resolve this issue.
Як писав сам Філатов,
As to his own words, his investigations are the brilliant pages of scientists among all scientific words. His way began in 1920. He was the head of departure, and it was his first surgery on cornea transplantation. This case was presented on March 13, 1920, on the meeting of Odessa Association of Ophthalmologists. Then we have another historical data. Volodymyr Filatov performed a first penetrating transplantation using his own developed instruments developed with Marcinkovsky engineer FM3, FM4, and they provide new level of security during surgery. Except of scientific and technical interventions, he provides a lot of science where to perform this surgery and new antiseptics. Then he launched new material and he expanded the grafts of cornea. And here you can see the donor material presented by Volodymyr Filatov. In 1936, Ukrainian Institute of Experimental Ophthalmology was launched, and Volodymyr Filatov was his director. It consisted of two departments. It was Department of General Pathology and of cornea transplantation. And here there were two laboratories launched in Ukraine on conservation and preparation of tissue, and it reached the world to the new investigation and openings in the treatment of eye diseases. Thank you. And now we give the floor to Ms. Halina Droshina. Dear colleagues, we are happy to greet Jose Guel from Barcelona, Spain. His specialization on transplantation of cornea, refraction and reconstructive surgery of anterior chamber of anterior part of eye. He's an associated professor of Barcelona University, and he managed the Institute of Microsurgery in Barcelona. He was the president of ICRS and Eurocorner, and now he's a director in both companies. He also moderates and modulate both segments. So we give you the floor to present your lecture. Visco-Dalk, the best approach to keratoplasty when endothelium is healthy.
Well, good morning.
Morning.
Could you hear me?
Yes, we hear you well.
Okay. So good morning from Barcelona. First of all, I would just like to thank the Ukrainian Society for the invitation. It is an honor, obviously, to present a Filatov lecture, being he, as you have nicely explained, probably one of the most important pioneers in corneal surgery in the world, but particularly in Europe. I would also like, as a trustee of the ESCRS Society, as the European Society of Cataract and Refractive Surgeons, which used to have a strong connection with the Ukrainian Society. I just wanted to let you know that we will definitely continue supporting as much as we can, and this is one of the goals of the ESCRS that we recently met in Copenhagen, and we decided as trustees of the society to continue with this cooperation. So again, many thanks for your invitation, and I will focus my lecture as a corneal surgeon in visco bubble talc. These are my financial disclosures, but none of them is related with this talk. Well, first of all, and to situate what I'm going to talk about, talc has obvious advantages in front of full thickness keratoplasty in any eye with a healthy endothelium. First of all, the perioperatory risk is much lower, so expulsive hemorrhage is almost impossible, and you have the anterior chamber stable during the surgery compared with a full thickness transplantation. Visual acuity and optical quality results are quite similar, but graft survival, again, logically, is much better for DALC in front of PKP because having not transplanted the endothelial layer, the rejection episodes are extremely rare, and the progressive endothelial cell loss that we classically observe after a full thickness transplantation or after any endothelial kind of transplantation, it is not observed after DALC. And also, in case of reintervention, which might be relatively common, for example, in some stromal dystrophies, because they are recurrent, the reintervention safety is much higher than the reintervention in full thickness keratoplasty. So it is obvious, or I think most surgeons in the world, that DALC is an advantage in front of full thickness when we have a healthy endothelium. And we as corneal surgeons should be pushed to use this technique instead of full thickness. So this is not something that we know recently. We are aware of these advantages since about 10 years ago, as it was clearly stated in, for example, the not the last, but the pre-last edition of the cornea book in 2017. So the problem with DALC and the main limitation for its use in front of full thickness is its surgical difficulty. In order to reach the most posterior layers, when we try to do deep anterior lamellar keratoplasty, there has been different surgical strategies suggested since the late 90s, using water, using viscoelastic, but in fact, it was when Ambar, a very elegant Egyptian ophthalmology, but working in the Middle East, described the technique of the big bubble. He described the technique using air and a needle, and it was the first technique where it was basically focused to directly dissect at the level of decimet, which obviously from a visual point of view has a significant advantage in front of any other deep dissections that are not reaching decimet level. After him, several other surgeons, including San Nicola from Italy, Tan from Singapore, Fogla from India, many others have described different variations of Ambar original technique. And I am going to focus on a technique where we described, also Shimura described in Japan, using either a cannula or a needle, but using directly viscoelastic to reach the dissection. The technique, as you can see in these two vignettes, short vignettes, it's basically once we have removed the 2/3 anterior thickness of the cornea, then use a needle to inject directly viscoelastic and create this big bubble. We will then decompress the anterior chamber because the dissection maneuvers will be much safer. And we can open this bubble without any fear of having a rupture because this bubble is, as I mentioned, plenty of viscoelastic. Then with the eye in soft conditions, constantly in soft conditions, we dissect these layers and we remove all the stroma, trying to reach the vertical cut because as cleaner this peripheral cut, the easier the adaptation of the donor lenticle, and so the better wound behavior and the better future astigmatism control. Obviously, not always we might have this big bubble dissection. Sometimes we have this, as you can see on the right hand video, a small bubble dissection with the visco, and then we should continue from this small bubble with manual dissection, a little bit slower, the dissection, but anyway, because with the small bubble we reached the posterior decimet duas layer, we can continue a little bit slower with the dissection. In 70% of the cases using this technique, the bubble, either large or small, is obtained. So in 70% of the cases, we reach this decimet level. As you can see in these videos, we need to reach these levels of is, I will put all them at the same time in order to save time. But basically the technique, independently of the problem of the case, is to remove these 2/3, these two anterior thirds of the cornea, which obviously are different if you're dealing with a keratoconus, or you're dealing with a corneal scar, or you're dealing with a dystrophy. So you should measure this preoperatively with your OCT, and then you will calculate how much are these 2/3. But as I mentioned, in 70% of the cases, as you have seen in the upper right video now, and you will see in the lower, and you will see in this other video, as I tried to mention in this slide, to reach the bubble is not always at the first attempt. So look at this, I have obtained the bubble in my third injection. But as I mentioned, you can have this large, big bubble dissection in 70% of the cases. And again, I repeat, constantly leaving the eye with low pressure, so decompressing through your paracentesis, you should continue with these dissecting maneuvers, and you will have a very nice posterior layer. And then from the donor, you will remove the endothelium and will continue with the surgery. sometimes when you move from a small to a large bubble, you might have, and that means that when you have a let's say local dissection on the pre-decimate layer, what is called the Duas layer, and also a focal dissection at decimate level, then you have two bubbles. This is type 1 and type 2 bubble. And sometimes in the with the movement, as you will see here, that you are injecting viscoelastic, these two bubbles will interconnect. And it might look like a rupture, but this is not a rupture of the posterior layer, but a rupture now, boom. This boom that you have observed is because the initial dissection was above Duas layer, and the secondary dissection was a decimate layer. You can see that the dissection is in the center, so you can continue with your dissection without any fear because there has been no posterior rupture, but just a rupture between the two bubbles. This is quite infrequent using viscoelastic, but this is relatively frequent using air. But as I mentioned, I think that there are many advantages using visco in front of air. In 25% of the cases, we don't get the bubble, and then we will need to continue with layer by layer dissection, as you will see in these videos. I leave to running all of them, but basically what you will see, these are again different cases. There are the keratoconus on the upper right is a secondary scar following infectious keratitis. The lower left video is a stromal dystrophy, and as well as it is another stromal dystrophy, the lower right video. So the technique, as I mentioned, is always the same. Calculate 2/3 of the stroma, which we removed with our lamellar knife, and then we try to reach the bubble. But in 1/4 of the cases, despite of consecutive injections, this bubble does not appear. And then in those cases, so we will inject, as you will see here, we will repeat the injection, and we will repeat the injection, and we will repeat the injection. But finally, we have not reached, we have the stroma, plenty of viscoelastic, but no bubble. So the viscoelastic, as it also happens sometimes with the air, has not reached the posterior layers. In those cases, then you should continue the lamellar dissection plane by plane, but using a manual dissection. And with this, again, the advantages of having the stroma plenty of viscoelastic is that your visualization is quite better than if you have multiple micro bubbles of air. Visualization is better. You have increased corneal thickness, and you have softened the stroma. So this manual dissection is obviously longer, but is quite easy. You need, as I mentioned in the beginning, to continue with this manual layer by layer dissection, always keeping the eye soft, because this dissection maneuvers with the eye soft does not put in tension the posterior layer of the cornea. Of course, if you have in your microscope an OCT, this has a couple of advantages. It's not mandatory to have it, but if you have it, it is easier to find the correct plane for the visco injection, and also is much easier to control during the dissection the remaining thickness of the posterior layers. So it is not a need, but is quite useful to have it in your operating room. Today, for an experienced corneal surgeon, I'd say usually working with DALC, micro or macro perforations do not mean at all that you need to transform from DALC to full thickness. So there are almost any kind of perforation that obliges you to move towards a full thickness. It will obviously make your case again a little bit longer, but you will see, for example, in this left side case, I will run it quicker. This is a keratoconus case. You will see that now, when we have our visco dissection, because this area is very thin, you will see that, boom, you can see that we have an anterior perforation, but then we start from this anterior perforation, the lamellar dissection, but with these maneuvers, now in the dissection, you will observe a rupture, boom, in fact, a explosion. Okay, that does not mean that you need to move to full thickness. You should continue slowly and obviously carefully with the eyes soft, as I mentioned, with your dissection. Continue your dissection, forgetting the area of the perforation, but leaving the remaining decimet in place. And at the end of the procedure, once you have sutured your lenticle, what you should do is do a inferior peripheral iridectomy and leave air or SF6 20% as you do in your DMEC or your DESIC cases in order to have it attached. And the same for a large perforation. You will see here, this was a small, the left one side one. But look at this, and let's go quickly. And you will see that here, in this manual dissection, at the end, now, we will have an explosion. You will see the explosion. Now, boom. And now, the cut is going from here to here. It's not a small hole. It's a absolute section of decimet. But anyway, you can still finish your dissection, position both flaps of decimet, and suture your lenticle, and again, leaving air after performing an inferior iridectomy. And it will take longer. Sometimes, as in this case, you will need a couple of SF6 reinjection in the following weeks after the surgery. But at the end, as you can see here, you will have a very nice, clear cornea. Obviously, you will always see this line where decimet was broken. So, I'm sorry. This is not moving. Now, this is exactly, this is what I mentioned. Well, obviously, the end result after 6 months, it is independent. If you have had a decimet dissection, like in this case, or you have a predecimetic dissection with some remaining stroma, look at 6 months. In fact, this is at 3 months, the appearance both at the slit lamp and an OCT, or if you have a predecimetic dissection with some posterior stroma remaining at 3-4 months on the OCT, you will see a very nice and homogeneous posterior layer. So as I mentioned, re-DALC is a relatively easy procedure. One of the advantages of DALC in front of this is a recurrent corneal dystrophy. So we remove the previous lenticle where the dystrophy has recurred, and we proceed with another transplantation. And this is a similar case where we have some remaining too much posterior stroma. We elevate this lenticle, we inject air, and we will remove this excess of posterior stroma that we have observed the day after the surgery, and we will put the same lenticle as we did in the original one. So re-operations are much simpler than after well, I'm sorry. So I have 5 minutes to go, or 10 minutes to go. So in those cases where you need to combine corneal surgery, doesn't matter if you're going to use DALC or full thickness, and you're going to do cataract surgery, there are different strategies with the goal of improving the refractive result. Obviously, if you do at the same time the corneal surgery, either full thickness or DALC, and cataract and IOL implantation, you should invent the theoretical postoperative case at the time of calculating the IOL. So that means a risk of significant ametropia postoperatively. So one of the strategies that I have been working with for many years in both full thickness and DALC is to, in the case that I need to do the surgery, so I need to do cataract surgery and deep anterior lamellar, is to do both things, but implant the lens in a secondary procedure. Because if not, the risk is the one that you can see in this surgery. So this is a case of an old lady with a woman of 73 years old. When, as I am close to this age, I don't think that 73 is too old anyway, but we usually consider 73 as an old individual. So she has as you can see, a significant terrienne and a cataract. So we planned, because she is from Portugal, in order to avoid a secondary surgery. In this particular case, we decided to do both things at the same time. So we have removed these 2/3 of the anterior cornea in order to have a good visualization to proceed with the cataract surgery. We are going to do a cataract procedure. And in order, as I mentioned, to avoid too much flights from Portugal, we implant, in this case, we proceed with the surgery, with the cataract surgery, and we implant an IOL, trying to assume that post-op case we're going to be our mean post-op case. And we then, at the end, finish our lamellar dissection once the lens is in place, and we proceed with the suturing the anterior lamellae. And the surgery, as you can see on the right top, was very nice. Everything was fine, but the ametropia was plus 18. And this is one example just to show you that these pre-op calculations may fail. So what we needed to do in this case is, at the end, asking this patient to come back, and we proceed with an IOL exchange. So in order to avoid this possible complication, as I mentioned, my standard strategy is proceed, as you can see with this video, we proceed with the surgery, and 3 with the cataract. So we have 2 strategies: to do the lamellar surgery first, and then some months later, with the actual case, do a complete cataract procedure. Or we can also do what, as I mentioned, I have been doing also in full thickness, not only as here in deep anterior lamellar, is to do at the time of the DALC to do the DALC and the cataract surgery, and then 3 months later, come back and with viscoelastic dissect the back and implant the IOL. This is especially useful in full thickness because the viscodissection and the implantation of the IOL as a single procedure has a much lower trauma component than a complete cataract surgery. So in those cases where you have done a full thickness transplantation, this strategy of implanting the IOL as a solo procedure months later is a much logical approach. And the probability of significant ametropia is much lower than when we do a triple procedure. Of course, you can combine DALC with SLED, as you can see in this patient with unilateral limbal deficiency. We are taking a small biopsy of the healthy eye, and we will put this biopsy in the other eye, and also we will do a deep anterior lamellar. So deep anterior lamellar obviously can be combined with any other procedure, as also here, in order to correct the residual significant ametropia in a young patient after DALC, we can use, and this is my favorite phakic lens, a artiflex, in this case, a toric artiflex, to correct the residual ametropia after DALC. So, in summary, descemetic or pre-descemetic DALC is our preferred technique when keratoplasty is indicated and the endothelium is healthy. Best corrected visual acuity and quality are similar than after full thickness, but obviously graft survival is much longer. There are rare limitations. Obviously, there are some situations, for example, in some herpetic cases, where we are unsecure of how good is the endothelial health, or in those cases where we have had a previously perforated cornea. This might have some limitations for DALC. And as I mentioned, I think that viscobubble dissection, this technique, is less aggressive. We have a slower and more controlled dissection, and the steps, the surgical steps, are safer with a much better visualization than using air. And just obviously, the use of an intraoperative OCT is useful as long as you can have. So thanks very much for your kind attention, and I am obviously open if there are any questions, if there is time for that.
Якщо є запитання, то запитуйте. Чи є запитання? Є. Будь ласка.
Are there any questions? Yes, there is some question. Please, Nadia Fedorovna.
Thank you very much for so nice.
Interesting presentation and some questions. Do you remove the remnants of viscoelastic from the surface of the cement membrane when you put the lamellar graft?
Well, not remember because I have not probably mentioned it, but you need to use if is a cohesive standard density viscoelastic, and so with flushing water over the ocular surface is quite easy to be removed. I do not recommend at all to use dispersive viscoelastic because dispersive, first of all, has not the same capacity for dissection, and secondly, it is much more difficult to be removed, as you know, in intraocular surgery. So the answer is yes, you should take some minutes flushing water to remove any remaining viscoelastic from the surface.
Thank you, understandable. And what is the risk to perforate the cement membrane using your technique with whisker or air bubble?
I'd say that the risk of perforation is exactly the same. So I don't think, I mean, during the
Would you like to ask?
Як то кажуть, in advance.
So,
Combination of keratoplasty and cataract. Перепрошую? Ну ось, кажуть, що він вже з'являється.
I can hear you. I can hear you perfectly well.
Okay, thank you first of all, thank you very much for great lecture. I have two questions regarding the combination of cataract surgery and keratoplasty. First, you advised to remove cataract and leave a phakic eye and then to visca dissect capsule. What's your opinion? Is it beneficial to use CTR, capsular tension ring, to implant in the capsule, and then it may facilitate us visca dissection? And the second question is, have you ever tried to combine cataract, keratoplasty, and aura? To do keratoplastic, then to do online refraction, and after on the transplanted corner, and then to calculate and to implant the lens. Thank you.
These are very, very good questions, in fact. And thanks very much for your comments. Well, the first one, yes, in fact, when 25 years ago, I started combining cataract surgery and full thickness keratoplasty and not implanting the IOL, what I was doing originally is implanting a zero-powered IOL at the time of the combined surgery in order to do not have any scar or any, let's say, connection between the anterior and the posterior capsule. And so when I implanted 3-4 months later the final IOL, the proper one with good case calculation. So what I did is let's say, an IOL exchange. I removed the zero powered and I inject the other one. This is what I did. So the idea of using a intrasaccular ring may have a relevance, but with the ring, what you will not be able to avoid is let's say, the connection between the rhexis and the posterior capsule. So you still will need to dissect this area. But anyway, it's a good idea. So yes, I think that this might be an option. And your secondary question, of course, that this should be the way to go. I have not tested this option to use the aura, so to use any, because there are new instruments to do that, not only the aura. So to use ray tracing to calculate, once you have left the eye aphakic, to calculate the proper power of the implant. But that's what we will do in the next few years, presumably in all cases. So I think that what you are just mentioning is what will happen in these cases that we have been talking about, of course, because these are the more risky cases. But I think that we will use this technology in every case. And because, as you know, ophthalmic surgery is rapidly changing, and we will probably not need it anymore in the near future, because machines will do our work. But in the transition period, machines will give us the opportunity to be safer and to be more precise. And I definitely think that any calculation during the surgery to properly align the lens and select the power will be in the near future the way to go.
Yeah. Thank you very much for great answers. And the only small comment, I hope that a machine will not substitute neither us nor our kids. Maybe our grandkids could be substituted by machines, and not fully. Thank you very much.
Okay. Well, I think that you should tell her. I think that doctors will be there, but I thought that it was gonna be for a problem for our grandkids, but I think it will be a problem for our kids. Anyway, let's see.
Шановний доктор Гуель,
Dear Dr. Guel, as to our tradition, every year scientists of our institution would honored doctor ophthalmologists that have significant researches and advantages in keratoplasty. So, for your research in keratoplasty and corneal grafting, we want to award you this year. We are very honored to present you this medal on behalf of Vladimir Filatov for your significant research in ophthalmology in the field of cornea transplantation and for your fruitful and informative lecture. Thank you very much.
цю нагороду ми зможемо
This award we will pass you on Eurocornea in Prague that will take place in Czech Republic in Prague.
It has been an honor, and it will be an honor to receive it in Prague. Thanks very much.
Ну, дякую, Галина Іванівна.
Thank you very much, Halina Ivanivna, very well. So let's move on. Keratoplasty cornea pathologies of the surface. So please, our first report